So what actually happens when you take a continuous release hormone ring and, place it right against biological tissue that has just been, well, intentionally and systematically injured by a medical laser thousands of times?
Yeah, it's a pretty intense scenario to think about.
Right. Welcome to today's deep dive. We are looking at a really fascinating stack of clinical sources today to see what happens when everyday birth control violently collides with cutting-edge tissue rejuvenation.
And we really are diving deep today.
We totally are. We're
Mhm.
looking at NHS contraception protocols, FDA safety communications, clinical guidelines on gynecological energy-based devices. And all of this is to answer a highly specific but highly practical question for you. Can vaginal contraceptive rings be used around the exact same time as vaginal tightening treatments?
Which, I mean, it sounds incredibly niche on the surface,
Ah,
right?
totally. Like, who is
Yeah,
Googling this exact combo?
exactly. But this scenario actually highlights a massive blind spot in modern medicine
Hmm.
because we have, millions of women relying on vaginal rings for contraception, while simultaneously the use of fractional lasers and radiofrequency devices in gynecology is just skyrocketing.
It's everywhere now.
It really is. So to understand if these two very different interventions can safely share the same biological real estate, we really have to look at the strict, demanding rules that govern how each of them operates on its own.
Yeah, so let's start with the ring itself. Nuvaring is the most commonly cited brand across our sources, and what makes this method so appealing for people is the delivery system.
The bypass, yeah,
Right, exactly, because unlike an oral contraceptive pill that has to, survive the harsh environment of your stomach acid,
which is brutal on medications.
so brutal,
Yeah.
and then it has to get metabolized by your liver before it ever even reaches your bloodstream. But the ring bypasses that entire gastrointestinal gauntlet. It's absorbing directly through the vaginal mucosa.
Right, because the vaginal mucosa is just highly vascularized, making it an excellent route for systemic drug delivery.
It's like a direct highway.
Essentially, yeah. The ring itself is a flexible, non-biodegradable polymer. And once it's inserted, it releases a continuous, steady dose of etodogestrel and ethinyl estradiol.
Okay.
And that suppresses the mid-cycle surge of luteinizing hormone,
Right.
which prevents ovulation while simultaneously altering the cervical mucus to basically create a hostile environment for sperm.
I always think of it like a slow release chemical sponge.
That's a good analogy, actually.
Yeah, and the sources, including the Better Health Channel and the NHS protocols, they make it super clear that the physical positioning of that sponge doesn't really matter all that much.
No, it doesn't need to be precise.
Right, like it doesn't have to sit perfectly over the cervix. As long as it is touching the vaginal wall anywhere, the hormones will absorb.
Exactly.
But while the physical placement is incredibly forgiving, the biological clock attached to it is it's brutal.
It really is a rigid timekeeper. The standard protocol dictates a very strict 28-day cycle. You have 3 consecutive weeks where the ring has to remain continuously in the vagina.
Continues.
Continuously. Followed by a mandatory 7-day ring-free window. And that drop in hormones is what triggers the withdrawal bleed. Then on day 8, a new ring just absolutely must be inserted.
Right. And here is where we hit a really fascinating discrepancy in the medical literature that you need to be aware of, especially regarding what happens if that continuous contact is broken during those active 3 weeks. Like, wait, what happens if it falls out or just needs to be removed for a bit?
Well, this is where the sources split.
Yeah, because the NHS Borders contraception protocol, it states that if the ring is removed for more than 3 hours, the contraceptive effectiveness is totally compromised. You have to rinse it, reinsert it, and then rely on a backup barrier method like condoms for the next 7 days.
And 3 hours is an incredibly tight window for a medical device.
It really is. But then, if you look at the family planning guidelines for the combined vaginal ring, they present a radically different threshold.
Right. They suggest the ring shouldn't be left out for more than 48 hours during that active phase.
No. Which is wild. Going from a 3-hour window to a 48-hour window is a massive clinical leap.
It's a huge jump. And the underlying clinical trials reflect basically differing conservative approaches to risk management.
Okay, that makes sense.
However, across all the clinical literature we've reviewed, the overarching consensus really remains the same. The pharmacokinetics of the ring rely entirely on uninterrupted mucosal contact to maintain those required serum hormone levels.
Right.
So removing it voluntarily is strongly discouraged, simply because the risk of forgetting to replace it within either of those windows leads to unintended pregnancies.
Wow. Okay, so you have this piece of flexible plastic that absolutely requires uninterrupted contact with the vaginal mucosa to function,
Correct.
which obviously creates an immediate mechanical conflict when you look at the clinical guidelines for modern energy-based devices, because those devices are designed to systematically target and alter that exact same mucosa.
Which brings us to the technologies that are often grouped under, vaginal
Right,
rejuvenation.
the laser.
Exactly. We are looking at fractional CO2 lasers like the Mona Lisa Touch, erbium lasers, and radiofrequency devices like Thermiva or the Vajazer.
Okay.
And it's important to note, these devices are not cutting tissue with scalpels. They are delivering controlled thermal energy directly into the mucosal and submucosal layers of the vagina.
Okay, I was reading through the mechanics of the fractional CO2 laser specifically, and it's fascinating. It sounds exactly like aerating a lawn.
Oh, how so?
Well, like when a landscaper punches thousands of tiny holes into a lawn, they are technically damaging the dirt, right?
Right.
But that targeted control injury actually forces the root system to panic, adapt, and grow back thicker, stronger, and healthier. The laser is basically doing that, but with light and water, right?
That is the exact biological premise, yeah.
Wow.
The laser energy is highly absorbed by the intracellular water within the vaginal lining. So when the probe fires, it vaporizes that water, creating these microscopic columns of thermal damage or microinjuries, while leaving the surrounding tissue completely intact to help speed up the healing process.
So the body reacts to these micro-injuries by basically sending in the repair crew.
Precisely. The initial thermal effect produces acute edema, so swelling, and following that inflammatory phase, the heat stimulates the fibroblasts.
And those are the cells responsible for like the structural framework?
Exactly, the structural framework of human tissues. This triggers neocollagenesis and neovascularization.
So producing new collagen fibers and new blood vessels.
Yes, the tissue completely remodels itself. So you're left with a thicker, more elastic, and highly vascularized vaginal wall, complete with restored glycogen levels and much better moisture production.
That's incredible.
It is. In the clinical setting, this is primarily utilized to treat genitourinary syndrome of menopause, or GSM, which causes severe atrophy, dryness, and pain. It's also used to treat vaginal laxity and mild stress urinary incontinence.
Okay, we do need to pause here for a second, though, because if you are out there researching these treatments, you are going to hit a wall of deeply conflicting information regarding their safety. And we want to present the full landscape here completely impartially.
We do, yeah. Because in July 2018, the FDA issued a very severe safety communication.
Yeah.
Warning against the use of these energy-based devices for vaginal rejuvenation or cosmetic purposes.
Right.
They stated these devices are not approved for these specific functional uses.
Yeah.
And they cited serious adverse events, including vaginal burns, scarring, chronic pain, and dyspareunia.
Which is pain during sexual intercourse.
Correct. The FDA's core argument there is just a lack of adequate long-term clinical evidence proving both the safety and efficacy for these specific conditions.
Right, so the FDA essentially threw up a massive stop sign. But then when you look at the responses from various gynecological clinics and medical societies and our sources, the pushback is really intense.
Oh, the clinical counterargument is very strong. They point out that technologies like the CO2 laser have a heavily documented 35-year history of safe use in gynecology.
Right, traditionally for treating things like cervical dysplasia.
Exactly. So clinics argue that the FDA's warning unfairly aggregates all energy-based devices, all varying power outputs, and inexperienced operators into one giant blanket statement.
Yeah, one of the clinics in the sources actually compared the FDA's blanket warning to discussing the safety of a car versus a bicycle.
That's a great comparison.
Right, because they're both modes of transport, sure, but the mechanics, the speed, and the safety profiles operate completely differently. A fractional CO2 laser and a monopolar radio frequency device are just not doing the same thing to the tissue.
Right, and many clinicians emphasize the vital role these devices play for patients who literally cannot rely on traditional pharmacology.
Like who?
For instance, breast cancer survivors.
Mm-hmm.
They often suffer from severe vaginal atrophy, but are strictly contraindicated for systemic or even localized hormone replacement therapy.
Oh, wow.
Yeah, so for them, energy-based tissue remodeling is often presented as one of the only viable alternatives to manage really debilitating daily pain.
Okay, so clearly a very complex landscape, and we always encourage you to discuss those specific safety profiles and FDA warnings directly with your doctor. But returning to our core mission today,
Yes.
we have a patient utilizing a mucosal-dependent hormone ring, and they are scheduled to undergo this thermal tissue remodeling. How does the clinical protocol manage the collision of these two treatments?
Well, if we look at the pre-procedure guidelines for devices like Thermiva, the directive is absolute. Patients are instructed to, quote, remove any internal birth control, such as NuVaring or other objects from the vagina, prior to the treatment.
Which makes sense. That is pure logistics. I mean, the practitioner needs unimpeded 360-degree access to the vaginal canal to, manipulate the laser or the radio frequency probe. You can't just have a plastic ring blocking the tissue.
Exactly. You need clear access.
But the treatments themselves are incredibly fast, right? Like, the sources note the Vajazer takes about 10 minutes. Others might take 20 or 30.
That's right.
So going back to our strict birth control timekeeper,
Yeah.
couldn't a patient just, I don't know, take the ring out in the waiting room, go get the laser treatment, and then just pop the ring right back in before driving home? I mean, that keeps the ring out for maybe 45 minutes total, safely under the NHS's strict 3-hour removal window.
Mathematically, that makes perfect sense.
Right.
Biologically, however, it is highly contraindicated.
Oh.
Yeah, post-procedure protocols across multiple sources, including the NICE overview on transvaginal laser therapy, they explicitly mandate a period of complete pelvic rest.
Okay, what does that mean exactly?
Patients are advised to avoid sexual intercourse, tampons, or any intravaginal devices for a minimum of 3 to 7 days following the procedure.
Wow, 3 to 7 days. I mean, I guess it makes sense. You just took a laser and vaporized thousands of microscopic columns into the mucosal lining. That tissue is in a state of acute localized trauma.
Exactly. The tissue is actively experiencing edema. The body is rushing fluid and inflammatory mediators to the area to begin the fibrin cascade and, rebuild the extracellular matrix.
So the vaginal wall is just incredibly vulnerable right then.
Very vulnerable.
Yeah.
Introducing a foreign, non-biodegradable object like a vaginal ring physically disrupts that fragile remodeling process.
And from a purely symptomatic standpoint, having a ring sitting against that aerated tissue just sounds absolutely miserable.
The side effect profiles definitely back that up.
Yeah.
Looking at the contraindications and post-op expectations for the SmartSide Touch laser, patients can experience mild to profuse watery vaginal discharge,
Yikes.
spotting, localized redness, inflammation, and tenderness.
Plus, anytime you break the mucosal barrier, you're basically opening the door for opportunistic bacteria.
The risk of infection is a massive compounding variable here. In the clinical trial data for these energy-based devices, vaginitis, which is an inflammation or infection of the vagina, is listed as a potential complication. Now, when you cross-reference that with the pharmacological data for the vaginal ring, vaginitis and generalized vaginal irritation are also listed as common side effects of the continuous hormone exposure.
Wait, really? So you have a laser that might cause vaginitis and a ring that might cause vaginitis?
Yes.
So if you put the ring into tissue that is already actively inflamed and weeping fluid from the laser,
Yes.
you are just exponentially increasing the risk of a severe infection.
You are creating a perfect storm for bacterial overgrowth or fungal candidiasis. This is exactly why the 3 to 7 day window of complete pelvic rest is completely non-negotiable in the literature.
Okay, so let's look at the timeline trap this creates for the patient, because the ring cannot be out of the body for more than 3 hours without fundamentally compromising the birth control.
Right.
But the laser demands the vaginal canal remain completely empty for 3 to 7 days to allow for structural healing. The math completely breaks down. Does a patient just have to sacrifice their contraceptive protection for a whole month to get this treatment?
Actually, no. They don't have to sacrifice their protection, but they do have to exploit the biological loophole built into the ring's schedule.
Oh.
Yeah. By synthesizing the rules from both protocols, there is a very clear strategic path forward.
Wait, the withdrawal bleed week?
Precisely. The ring has that mandatory 7-day ring-free period every single month. And laser treatments are typically structured as a series of 3 separate sessions, spaced roughly 4 to 6 weeks apart.
Okay, I see where this is going.
So a patient can perfectly synchronize their treatment plan by scheduling the laser session on day 1 or day 2 of their ring-free week.
That perfectly threads the needle.
It does.
The laser happens on Monday. The tissue gets Tuesday, Wednesday, Thursday, Friday, and the weekend to undergo the acute inflammatory and healing phases without any physical disruption whatsoever.
Exactly.
Then, right on schedule, the brand new ring goes in the following week. The vagina is empty for the required 7 days, but because the biological protocol of the ring actually demands it be empty that week anyway, the patient's systemic contraceptive protection never drops.
It perfectly honors the biological requirements of both the energy-based device and the pharmacology of the ring.
That is so elegant.
It is, however, this level of calendar coordination requires a highly organized patient and frankly, a highly accommodating clinic schedule.
Yeah, because real life rarely sticks to a perfect 20-day schedule. What happens if the clinic is booked out for months and the only available appointment for the laser falls right in the middle of the patient's active 3-week ring phase?
Well, if the timing simply doesn't align, the backup protocol reverts to the standard contraceptive failure guidelines.
Okay.
If the ring must be removed during the active 3-week phase to accommodate the laser, the patient will obviously violate the 3-hour rule because the ring will be out for the entire 3 to 7 day healing window.
Right, which means the systemic hormone levels are going to drop and ovulation could occur.
Correct. Therefore, per the NHS protocol, they must treat it as a missed pill or a dropped contraceptive dose. Once the vaginal mucosa has adequately healed and the ring is finally reinserted, the patient is completely unprotected.
So they need a backup.
Yes, they must use an additional barrier method, like condoms, for at least 7 consecutive days after reinsertion to ensure ovulation is suppressed and they are fully protected against pregnancy again.
Okay, so it is entirely manageable as long as you understand the underlying rules of both systems.
Exactly.
But we also need to acknowledge that simply mapping out the calendar doesn't automatically qualify someone for this combined approach, because both of these treatments have rigid exclusion criteria, right?
They do, and shared and conflicting contraindications are absolutely vital to consider here. The vaginal ring, due to its systemic hormonal effects, is strictly contraindicated for women over 35 who smoke, patients with a high body mass index, or anyone with a history of deep vein thrombosis, pulmonary embolisms, or cardiovascular disease.
And the energy-based devices have their own red lines.
They definitely do. The lasers and radiofrequency treatments are strictly contraindicated for pregnant women, patients with active vaginal or vulvar infections like active herpes simplex or candidiasis, and importantly, anyone with a history of reconstructive pelvic surgery utilizing synthetic mesh.
Oh, because of the heat.
Right, the thermal energy can interact disastrously with internal synthetic materials. So a comprehensive medical history is the first unavoidable step.
Wow. Okay, bringing this all back to the mission we started with. Yes, vaginal rings and energy-based tightening treatments can be utilized by the same patient,
Yes.
but they absolutely cannot share the same biological space at the exact same time. Navigating this requires a deep understanding of your cycle, meticulous calendar synchronization, and very open communication with your gynecologist.
It really highlights how proactive patients have to be. But, synthesizing these sources actually unearths a much larger, lingering variable.
Oh.
Yeah, and it is a fascinating blind spot in the current medical literature.
Okay, we've solved the mechanical overlap, but what about the biological aftermath? Is that what you mean?
Exactly. We established that energy-based treatments fundamentally remodel the cellular architecture of the vagina.
Right.
Post-treatment, the patient has a thicker mucosal wall, a denser collagen matrix, and significantly increased neovascularization, meaning a much higher density of blood vessels.
Okay, yeah.
We also know that the new varing relies entirely on absorbing its specific daily dosage of etinogestrel and ethinyl estradiol right through that mucosal wall into the systemic circulation.
Wait, so we have just permanently upgraded the infrastructure of the delivery route.
Exactly. If the tissue is suddenly thicker, more robust, and highly vascularized, does that alter the absorption pharmacokinetics of the contraceptive hormones?
Oh, wow. It's like upgrading the walls of your house from drywall to reinforced concrete, and then wondering why your Wi-Fi signal drops.
That's a perfect way to look at it.
Does the denser collagen network act as a physical barrier, slowing down the absorption of the hormones and potentially dropping the serum levels below the threshold needed to prevent ovulation?
Or conversely, because there is increased blood flow and heightened vascularity right at the surface of the mucosa, does the ring dump the hormones into the bloodstream too quickly, creating a spike in side effects like nausea or breast tenderness?
That is a massive variable for something as critical as preventing an unwanted pregnancy. I mean, do any of the clinical guidelines or FDA warnings address this altered absorption rate?
They do not. The sources we have reviewed are completely silent on this specific interaction.
Really?
Really. The clinical trials for the ring were conducted on standard baseline vaginal mucosa. The trials for the lasers track tissue health, not the systemic absorption of secondary pharmaceuticals.
Oh.
It is a profound gap in the current data and a vital question for the future women's medical research as these overlapping technologies become the standard of care.
It is an incredible reminder That our biology is not just a series of isolated, disconnected compartments. The dentist isn't just looking at the tooth, and the laser isn't just treating the tissue.
Everything is connected.
It really is. Every intervention echoes through the entire system, and sometimes the clinical guidelines just haven't caught up to the reality of how these treatments collide. Well, thank you so much for joining us on this deep dive. Keep coordinating those calendars, keep talking to your doctors, and most importantly, keep questioning the systems and the science around you.